Very long name, I know that. It's a great pleasure to be in here. I will be going on in English language. And in fact, I must admit, this is one of the few speeches that I'm doing in English, so I will probably do it in what we call universal bad English language, which is the scientific language of all non-foreigners, let me say. I will today be talking about a very ambitious topic. I will try to talk about first spinal-induced hypotension and the management of hypotension, and I will also be trying to go on for some patient-related factors for intrathecal anesthetic spread. I'm sorry, this just goes on without me. Now, for that kind of an ambitious topic, let's first start with spinal anesthesia. Single-shot spinal anesthesia is commonly preferred in an elective cesarean delivery because it has a better visualization of success. You can see at the end of your needle the CSF, which translates to low failure rates, and you can have a quick onset that also translates to faster skin incision and efficient OR utilization. It gives you a superior quality of anesthesia, and because you're giving minimum amount of local anesthetics to the neuroaxial system, it has a negligible maternal risk for local anesthetic systemic toxicity and minimal drug transfer to the fetus. And unless you're putting in another catheter or another local anesthetic over the time, you're also having a good chance for early ambulation. Oops. But there are some problems with giving a fixed dose of local anesthetic to the spine. What is that? On one hand, you might have an inadequate anesthetic level that is associated with pain, nausea, and vomiting due to unblocked peritoneal stimulation, and sometimes a need for general anesthetic or another type of anesthetic supplementation. On the other hand, you might have an overresponder that has a hypotension, again, hypotension-related nausea and vomiting, prolonged motor block, high spinal resulting in respiratory muscle weakness, prolonged PACU stay in an excessive anesthetic spread. It's not easy because the intrathecal drug spread, in fact, depends on many factors, including characteristics of your injected solution, the clinical technique that you use, the position, the needle, the level of the injection, the speed of the injection, and some patient-related factors. Today, I'm going to be talking about the right side of the slide. That is, I'm going to be talking about the hypotension and also patient-related factors. Now, is hypotension a problem? Yes, it is a problem, because when we give spinal anesthesia, if you define hypotension as blood pressure less than 80% of the baseline or a systolic blood pressure less than 100 millimeters mercury, the incidence rises up to 71%. And nausea, vomiting, and syncope can be seen in the maternal side effects, and for the fetus, impaired uteroplacental perfusion, fetal hypoxia, acidosis, neonatal hypodepression can be seen. There are some risk factors related with BMI, sensor block height, dose of drugs, increased infant birth weight, increased baseline sympathetic tonus, and maternal age. But the problem is that we used to think hypotension predominantly resulted from the venous return decrease due to preganglionic sympathetic fiber blockade. This, coupled with the aortic wall compression, resulted in a blood pressure decrease and a cardiac output decrease. Now, is there an aortic wall compression? Yes, there is an aortic wall compression, and it's a big problem in a parturient that's lying spine. This study was from 2015 by Higuchi and friends, and as you can see in here, let me try to show you from here. The inferior vena cava is totally collapsed when the patient is lying spine, but once you start to laterally lift the patient to 15 degrees only, you can see a little bit of increase in the inferior vena cava volume, but it's not great. Once you do a little bit more of the tilting, you can see that it has started to open up, and in fact, if you further increase the laterality to 45 degrees, you don't have that much of an increased effect. What does this tell us? It tells us that the obstetric anesthesia table tilt that we usually use at 15 degrees is not, in fact, enough to really relieve our inferior vena cava volume. Aortic wall compression is important because also in some patients, coupled with hypotension, there is a sudden onset of bradycardia that you cannot only explain with this decreased inferior vena cava volume. There is a reflex unfilled ventricle response that contributes to it, and this is called the spine hypotension syndrome, which early treatment and immediate treatment is necessary. But other than that, people used to think that if we could increase the central blood volume by giving more fluids, by doing leg lifting so that we can really take back the venous blood from the extremities back to the central volume again, or by doing a mechanical compression of the legs, we could in fact solve all these problems and maybe reduce the incidence of hypotension, spinal-induced hypotension completely. The first group to really advocate for the fluids were the Gertie-Max group, and they did a very small study. Later on, dozens of studies came, but we saw that it was not that much of effective. We saw a little bit of moderate effect with colloids more than crystalloids, but there was not that much of difference with the preloading or the co-loading. So why are the fluids not working? The answer came with another study doing beat-to-beat cardiac output monitoring. This study showed us that, contrary to our belief, the issue was arterial vasodilation, not a venous decrease. The arterial vasodilation resulted in a systemic vascular resistance up to 35%, and there was an initial compensatory increase in heart rate. There was an initial compensatory increase in cardiac output up to 22%, despite a preserved stroke volume and a decreased blood pressure. It's very difficult to understand, to make sense of all these graphs in here, but I will try to especially color the worst group to you. This Langstetter study did two groups with two different situations. That is, one with 7 milligrams, one with a 10 milligram of propofol, with or without phenylephrine. As you can see in the worst group in red, there was an increase in cardiac output. There was a decrease, immediate decrease in systemic vascular resistance, but the systolic and the mean arterial pressure decreased immediately. So, if the problem is not a problem of the venous return, how shall we solve it? It seems physiological and logical again that we should be giving vasopressors to ameliorate this situation, not trying to increase more of the central blood volume. We have a lot of vasopressors. And unluckily, not all vasopressors are created equal. In my residency, ephedrine was the vasopressor of choice because in animal studies, it was shown that it preserved uterine blood flow very well. Ephedrine has a relatively slow onset, and in terms of maternal hemodynamics, if you look at it from here, you will be able to see that once it's employed, it gives a blood pressure response later, and it causes an increase in cardiac output. It also causes an increase in heart rate. Now, compared with that, phenylephrine has a very immediate onset, and it causes an increase in mean arterial blood pressure, but it causes a decrease in cardiac output, and also it causes a decrease in heart rate that corresponds to that decrease in cardiac output. You might wonder, why would I want to really decrease cardiac output? But please remember that, in fact, this is not a real increase. We are only preventing the possible compensatory cardiac output increase in here, as you can see. One of the problems with ephedrine was that ephedrine was able to pass the placenta much more than the other vasopressors, resulting in increased lactate and increased glucose and increased catecholamine concentrations in the fetus. And this translated to a 5 times increase in fetal acidosis. So we do not like to use any more ephedrine, but we prefer phenylephrine. Phenylephrine infusions, especially prophylactic infusions, have been shown to be very good in managing spinal-induced hypotension. And there were some issues with dosing. There were lots of studies trying to find the ideal dose for phenylephrine infusions. The first proposed dose by Niganki, who first, in fact, got us on the plane with this vasopressor, was 100 mics per minute. And he showed that he was nearly completely able to eliminate the hypotension with this kind of a drug infusion. The problem was that it was also associated with reactive hypertension. And then other studies came looking at different infusion rates like 25, 50, 75, 100 mics per minute. And they were able to show that reactive hypertension was seen more commonly in 75 to 100 mics per minute when compared with the other groups. And therefore, usually nowadays we're starting with 50 or 25 mics per minute and then trying to titrate the dose accordingly. There were also studies looking at variable rate of infusion and saying that if you could really titrate the infusion according to heart rate or according to maternal hemodynamics, it's going to be much better than a standard infusion. There are even computer-controlled infusions nowadays coming that will probably be everyday practice in obstetric anesthesia. Now there is a new kid on the block, and maybe one of the topics that this presentation is going to be focusing. Phenylephrine has a problem. It causes a cardiac output decrease, as I said, but it also causes a heart rate decrease. This is not something that you would not like to be dealing with in a parturient that has not reached yet the blood pressure that you want, that has nausea and vomiting, and you have a heart rate going down. Now, if we could find another vasopressor that can conserve heart rate while preserving all the hemodynamics, that would be ideal. Therefore, Nganki have proposed in a 2015 article that we should be using norepinephrine. Norepinephrine has a faster onset than phenylephrine and therefore much easier to titrate, especially in a computer-controlled system. And in their study, they did a closed-loop again delivery of norepinephrine, and they gave 5 mics per minute of norepinephrine infusion versus 100 mics per minute phenylephrine infusion. And they were able to show that there was no difference in stroke volume, but they were able to maintain the cardiac output and also systemic vascular resistance much better with norepinephrine. Now, this was the first group to talk about norepinephrine. There is also an oncoming study there was also another study from Alejo and friends, and they also looked at norepinephrine. They could not do a double-blind study. They were able to perform an open-labeled comparison of norepinephrine and phenylephrine, and they looked at the rescue ephedrine need in both groups, and they found that in the phenylephrine group, rescue ephedrine need was increased. And again, another study in 2017 came if we could give this norepinephrine as a bolus, and they found that the effective dose of 90 for norepinephrine was 5.49 mics. And recently, again, Nganki has also published his spinal anesthetic experience with norepinephrine infusion that was close to ED90, that's 6 mics per minute. And he said that he did not encounter any problems either fetally or neonatally or maternal hemodynamics. But there are still some concerns. We have a decade of experience with phenylephrine, but we do not have that much of experience with norepinephrine. So we will probably be seeing a lot of studies with dosing, with methods of delivery, although there are also some concerns raised because of possible tissue injury due to extravasation, local vasoconstriction, and dilution problems. Now let's go on to the other topic, from the hypotension back to the patient factors. It seems attractive that if we could first see and look at a patient and then try to understand how much local anesthetic that we need to give to have an adequate anesthetic level so that we don't encounter hypotension or we don't go for a necessitation of general anesthetic supplementation. And it's not, in fact, an early dream. It has been studied many, many times, and it has been repeatedly found to be negative. There are some small studies with positive results, but it has not been, again, repeated. A recent study from Lee and friends has looked at another thing in terms of patient anthropometrics. They looked at the abdominal circumference, and they thought that because neuroaxial system is a 3D system, they could much more better predict the effect of the gravid uterus on local anesthetic spread with abdominal circumference rather than other variables such as weight and height. And they combined this this factor with trunk length, what is the length from the C7 to the sacral hiatus, which gives, in fact, your vertebral column length, and they divided it with abdominal circumference squared, and they were able to say that they were able to predict the probability of the spinal level in a given local anesthetic, and they were even able to say that it was either high or low according to the given probability. Another study tried to do the same thing, but in a different setup. They gave a standard amount of local anesthetic according to the heights of the patients. So there were three different doses, 10 milligrams, 11 milligrams, and 12 milligrams. And they measured the abdominal circumference, and they tried to see if they could predict the spread of the local anesthetic by looking at the abdominal circumference. They were not very, they could not find a good correlation. They could only correlate it with the early spread of the spinal anesthetic. A very recent article, in fact, it's an article in Press, I'm so sorry, has looked at the same thing. And they found a correlation with abdominal girth, that's the abdominal circumference, vertebral column length, and spread of intertracheal hyperbaric bupivacaine in the term parturient. So what's happening? Why is there some people that saying there isn't a relationship, and why are there some people that could not find anything? Now, remember that there is a decreased local anesthetic requirement in the parturient. That's because there is an increased sensitivity to local anesthetic due to biochemical and hormonal changes, but there is also direct anatomical changes with the parturients. The lumbosacral CSF volume and the dural sac area, especially in a lying spine pregnant patient, is decreased, and this has been shown in MRI studies. Now, the MRI study that was first able to demonstrate it was Hirabayashi, and he took a patient lying spine when she was non-pregnant and then compared it to the time that she was pregnant. And he was able to see that in the pregnant patient, the inferior vena cava was completely pressed, and it caused a diversion of the venous blood to the anterior venous, epidural venous system, and therefore he said this anterior venous system engorgement results in dural sac narrowing, causing a decrease in lumbosacral volume. The same thing was also shown by Taguchi and friends, as you can see in here, but they also observed another thing. They saw that intervertebral foramina there was also a forward movement in the intervertebral foramina, causing a decrease in local anesthetics, causing a decrease in the lumbosacral volume if you look at the vertical plane. Now, how can this inward movement of soft tissue be explained? They thought that this was due to an increase in retroperitoneal pressure, that when the patient lay supine, there was an increased abdominal pressure, and therefore that caused the decrease in lumbosacral volume. Well, the ultrasonography studies could not really relate at first very well with the anterior-posterior diameter of the lumbar sac, but they were able to a little bit predict with dural sac length, which they did in a sitting position in a parturient. They looked at from L1 to S1 ultrasonographically in the parasagittal plane and tried to correlated it with the peak sensory levels. We did a study that we looked at if this theory, the increased intra-abdominal pressure for intraforaminal soft tissue laterally decreasing the dural sac volume is true, and we could not find an association with intra-abdominal pressure and maximum sensory block level. So it is still a little bit of shaky if we would ever be able to predict the spinal anesthetic spread, just looking at the anthropometric measures of the parturients. And I would especially caution you against it if you're only dealing with a single shot spinal anesthesia, because please remember, if you do not have any method to extend the block any further, and if you're dealing with doses lower than 10 milligrams, lower than 8 milligrams, then you have an increased rate of failure. You may get away with it in some patients, but that's not guaranteed that you will be able to get away with it in all patients. And for the vasopressors, the future is bright. I think there's going to be new kids, more, or let me say, old kids returning back to the block. And there will probably be more interesting studies coming on. There are some issues still with vasopressors. We still do not have very good data on how they are doing in high-risk patients. There were only 2 studies coming from preeclamptic patients for phenylephrine. We do not have anything on noradrenaline, but I hope that this will be also solved in the future. Thank you for your attention.